Okay. I just wanted to let you know this is when the reporter. And maybe this
They know
Okay, welcome back. Let's get started with our second session. Our second session focuses on data, system, infrastructure, and their impact on society and research. We will have 3 speakers. And this session is a little bit different from first session. We're going to have our speakers talk about their experience with their data and their systems and the research they learn from their data. And then we will have a time for panel discussions and questions from the audience. So our first speaker is Dr. Beth Blauer. She is the Associate Vice Provost for the Public Sector Innovation at Johns Hopkins University, where she oversees the Bloomberg Center for Government Excellence and the Bloomberg Center for Public Innovation. We all know that under her leadership, the center actually was notable during the pandemic for hosting and supporting the Coronavirus Resource Center, and we all know as the Johns Hopkins data portal. Okay. So today, she will mainly focus on the coronavirus resource center and how the promise and the perils of the public health data infrastructure. And Beth, it's your turn. You can share your. Let me.
All right.
Yeah, you can share your screen.
Okay, I'm using let's see here. I'm gonna share my screen. And it should be here. And then I'm gonna actually play this. So if you could, Dr. Lee, just tell me if you can see it when I play it. Can you see you can see everything? Great.
Yes, great.
Okay. So thank you so much for having me and for allowing me to be a part of this very important conversation. I'm really excited to be here with you to talk to you a little bit about kind of our work around COVID, but I would like for us to keep a sort of high level understanding around public health infrastructure in general and kind of the opportunities, but also some of the really specific challenges that we faced doing our COVID work here at Johns Hopkins. And so I thought that I would start just as like a way to talk a little bit about how we ended up becoming kind of the authoritative source on COVID early on in the pandemic. The history is exactly as it has been told, is that we had a very entrepreneurial graduate student who was thinking about his PhD and had tapped into some news from home that there was a sickness that was spreading through a local community. And as part of his research, wanted to be able to model the outbreak. And he was working in a modeling team. And so together he and Dr. Gardner, my colleague, started to do this modeling. And they decided to use a GIS application as a way to communicate how it was going, because this is how they track other communicable diseases like measles and other, big impediments to public health. And so that is really how we ended up getting started. We very quickly became the only source. So the fact that we were doing an international draw, relying on public data, but creating some data infrastructure here at Hopkins, it became evident that the public health field, whether that's the WHO or local CDCs, were not really kind of positioned to be able to do this kind of data collection. And so for the first stretch of COVID, the Johns Hopkins Coronavirus Resource Center and the map and the data that we created in the data pipeline became the authoritative source. And that required us to think really sort of tactfully about what it means to be the ambassador of a vital resource right from the start. And that we needed to do this adhering to some internal governance principles that we know are best for open data, for sharing data, but also for understanding this data, because it was in many cases novel data that we were inputting. We thought this was a temporary effort, that we were just going to be filling a void until the sort of formal systems were able to catch up with us and able to kind of firm up that infrastructure. I don't think any of us would have said 3 years on that we would be calling it quits in the absence of a replacement. We knew that it was being heavily leaned on, not just domestically, but internationally by international and domestic NGOs, by governments, by policymakers, by Fortune 500 companies. People were using this data to inform, particularly at the beginning of COVID, those day-to-day decisions about whether or not their workplaces were going to be opened, whether they were going to have their economies or schools open. And they were using the data to navigate those challenges, which were at the time the only mitigating strategies that we had from a public health perspective. We started to bring together, one of the benefits of being at a university is that we had very strong public health expertise, very strong data expertise. We had experts that we could bring in as part of this governance process. And so we really did create a sort of intersectional group of governance that pulled from every corner of the university, both on the processing and releasing of the data, but also in the subject matter expertise to bring the data to life, to allow the data to sort of align to tell a story in a way that could deeply inform decision making. And I think that translational role is actually a very good role for higher ed. I don't think necessarily that we should be the providers of the data, but I think that translational work is really critically important. To give you a sense of kind of the data pipeline and how we ended up building this, it was a very manual process from the beginning. We kind of combed to see where authoritative sources existed. So we were looking at sometimes government websites that had data that was being pushed out. We were looking sometimes at Twitter. We were looking at sometimes, at aggregation that was happening in regional instances. And we were pulling all of that data in very manual formats, trying to bring it all into one place so that we could start a process of normalization and understanding the data, start to create some crisp definitions around the dimensions of the data. And we really spent a lot of time just talking about the data, entrenched in the data, bringing it in, and really fundamentally understanding it, which I think is one of the most critical roles that we played, was that we just got steeped in what was available. And then we started pushing out opinions on how the data should be formatted and what we thought were the best ways to start talking about COVID from the perspective of the data itself. So when I say manual, it was manual. We're pushing them into web-based spreadsheets, and then we were then using at the beginning like ESRI sort of open tools in order to build the GIS front end, and then eventually we started to automate a little bit of that work. So the partnership, which was really critical to the success, brought together a few different sort of critical entities. And the early partnership was really a reflection of our commitment to the data quality. And so we were bringing in our APL, which did our data processing. Whiting, our engineers, were responsible for really framing and shaping what the data looked like. The Sheridan Libraries was making sure that we were creating a long-lasting research nucleus that was going to be able to be applicable both in real time for modeling, but also long-term for that research, and then a partner at Esri. I want to just call this out is because these are skills that are not always developed in government or in public NGOs that are responsible for health infrastructure. And so when we talk about opportunity to use COVID as a learning mechanism, one of the things that I think is going to be critically important is what are the kind of emergent skills that were required for us to be successful in this work that we should be seeding in public institutions in order for them to actually be able to be responsive to the next pandemic, or to think about other big challenges around chronic disease and some of the other big impacts that we know have effects on the community. And so the pipeline, once we started to really understand this data, started to also mature. And we started to really think about how we can create more automation across the way that we were pulling data. We started to do a lot more curation and really started to also reflect our standard back onto data that we were pulling in to make sure that the very best data was actually making it to the public. And so we created internal processes where we would essentially govern the data as it was coming in, and we would move it from these sort of mass collections through that curation process into production. We also created anomaly detection, starting with the sort of manual error recovery. So when we were looking at the back end of the data, we were able to actually have sort of fundamental flags that would tick off to us that we were also pushing into other communication strategies, so that our 24/7 operations could look at data if data was not sort of rendering in the right way at any point in the process. And that's when we started to expand our relationship, where we started to bring in some of the more front end amenities of the site. It allowed us to think about that translational work. We had this massive amount of data now. we needed to start telling the story. We needed to start visualizing that data. And so again, another skill that really, I think, is absent in a lot of the way that we think about public health infrastructure is how do we create data translation in the form of maps and charts and graphs that can guide decision making, whether that was you're going to wear a mask to the grocery store or whether that was you're going to be prioritized for vaccination. All of these things were deliberations that needed a healthy base of data in order to guide those decisions, and that wasn't necessarily what was available. There were obviously big challenges to pulling data from, in the United States alone, over 3,000 local health departments. We were pulling data from every state. We are obviously still doing a global data pool. And the reality was that every jurisdiction defined things slightly differently. There were variables that didn't align. It required methods of collection that had to be variable because the pools weren't all the same, systems weren't all the same. Not everything was automated so that we could pull it out. Some of it was still manual, so we had to do blended pulls. And we had to also make sure that we were sort of being as accurate as possible. It took a tremendous amount of engineering to be able to do it. And it, like I said, was a 24/7 effort, which meant that, again, we were able to pull those resources in from a university perspective. It's unclear whether or not our public health infrastructure across our country or the global perspective has the capacity to really support an effort at this magnitude. So we continuously were learning throughout the process, and we were obviously trying to add as much automation and as much fusion as possible into the process so that it allowed us to reduce the kind of stress and pain points on the collections themselves. And so as we continue to evolve the front end, we also were always looking at opportunities to optimize the back end. And we saw a lot more breadth in the ability to embed anomaly detection and also to understand what recovery would look like in the process of data processing. There also were expanded and retracted sourcing so that we were able to be elastic on that front end, but qualify and continuously use that governance process for qualification on the data itself. And then we saw a lot of automation that allowed us to be a lot more precise and also understand the kind of larger network of how data is moving throughout the global perspective from public health. And the good news, bad news there is that it's very difficult. It's not something like we've opened a pipeline that we can now pull a lot of diverse data through. We had to do a lot of specific curation for these pulls, and I'm disappointed in kind of the elasticity of the data and the way that the data moves through systems because of the fact that it had to be so bespoke. This infrastructure, the question is, can it be applied to solving other problems? And I think the process pieces can, but the actual physical infrastructure is very much focused on COVID. And because of the way that we are governing public health data, that scale is still unclear. But because we were in this pole position, we were able to really become a voice of the field itself. And we became the backdrop of a lot of really critical conversations around the future of public health data, the future of public health infrastructure as it relates to public health data. And we continue to do that kind of advocacy. It had a op-ed just this past weekend in the New York Times where I make pretty explicit calls with my colleagues across our leadership team here at Hopkins for the CDC and the national network to really think differently about the way that they approach and handle public health data and public health data infrastructure, including building out some of those really needed skills. I think another big piece that I want to make sure that we don't gloss over is the fact that we did become the trusted source for public data. And is this an ongoing role for higher ed to think about? In the presence of a lot of politicization around COVID, we were able to kind of be a steady state. Although we obviously took our lumps, there were definitely opportunities for us to continue to position ourselves as that trusted partner. And I think that also called a lot on the fact that we were very transparent about our methods. We were very transparent when the data looked funky, why it looked funky, everything that we learned about it. All of those things were detailed across our platform. And I think that helped build trust. So when we think about public trust and open data, I think some of that like messiness in the methods and getting that information out was possible. We had a very loyal audience. Both, you know, on the site, in our active opportunities for live briefings. You know, the site itself was very popular. But I think one of the other things is that we were not just doing this for researchers. It became the tool that my parents were using as they navigated their decisions. And, you know, it became a very democratized tool. And people really were looking at it a lot. And integrating it into a lot of their daily life. And, you know, that translated into probably the largest web effort I will ever work on in my entire career, hopefully. With over 2.5 billion page views, we had hundreds of millions of users, and a lot of time spent on the site. And we saw that ebb and flow, just as we saw the demand for information ebb and flow as the virus became more intense or reduced in intensity. And so all this to say is that, you know, we have this massive opportunity to do things differently in public health. We can't do it without data at the center. And we don't necessarily have the invested infrastructure. And so I would be, you know, very happy to field questions when we talk about it, but I think it's a starting point to use the lessons that we certainly have used over the last 3 years to kind of inform a conversation around what the future of this work looks like. So I'm going to end it there.
Thank you very much. How about we finish all the 3 talks and then we have questions and answers together. So our next speaker is Dr. Hanna Ollila. She's the FIMM-EMBL group leaders at the University of Helsinki, and also affiliation with Massachusetts General Hospitals and Harvard Medical School. And their group worked on the understanding of long COVID and autoimmunity. And they actually work closely with national, international organization on, it's called human genetic initiatives for host and virus interactions. And her talk is about understanding of genetic risk factors for long COVID, leveraging international collaborations for discovery.
Okay, thank you so much. And I can also probably share my slides from here.
Yes.
If that's
Yes,
okay, perfect. So let me do that. And then I'm going to ask you if all looks good.
Yes, very good.
Perfect. And I'm going to take a little bit different stab on building the infrastructure and using global data and Nordic data to understand something very new. And with something very new, I of course mean long COVID, a new disease that we have encountered. And I'm a genetic epidemiologist and I do sleep research. And sometimes we have this notion like, what does sleep has to do with infections? And I encourage everyone to think about like what they do when you're sick. And I bet majority of us spend a fair amount of sleeping. And the examples I'm going to give here are like 2 topics. One is like, what kind of infrastructure and resources do we need to achieve what we want to achieve? So that is to understand the disease and the biological consequences. And the second one is how to leverage existing infrastructure. So when COVID-19 hit, there was actually concern pretty early on among infectious disease specialists and particularly with neurologists, because we have quite good understanding that diseases lead to long-term problems. And there are some great examples of chickenpox leading to shingles, or HPV leading to cervical cancer, and of course, then HIV leading to cancers via immune suppression. And with COVID-19, we now know that there are at least 2 different outcomes for those that don't recover fully. And one of them is the MIS-C, and one of them is long COVID. And to really understand, first of all, the symptomatology of the disease, what we did in the Nordics with our Nordic collaborations first was there were these reports of like sleep component, exercise intolerance, headache, shortness of breath, gastrointestinal problems. So we leveraged the Nordic research data where each individual is linked to a common healthcare system and data set through a social security number. So we built using data from Sweden together with Ann-Marie Fors-Connolly, a cohort that had COVID positive individuals and then COVID negative individuals. So this data set covered the whole population of Sweden. And because Sweden had a little bit different strategy for managing COVID early on, even by the end of May 2021 or May 25th, 2021, there was a relatively large number of COVID positive individuals. So we had over 1 million individuals from Sweden who had COVID-19 infection, and that's about 10% of the total population. And then, well, some of them died, we couldn't include them in the analysis. And then some of them had then later received a diagnosis for long COVID. And then we could compare and understand the symptomatology of long COVID and how clinicians were giving the treatment codes for long COVID, comparing those individuals who had had COVID-19 but recovered to those who had COVID-19 and developed long COVID, and finally to those who were control individuals and did not have COVID infection nor long COVID. And if we do this analysis, there are 2 things I want to draw your attention to. And first of all, the ICD-10 code hadn't been available for that long time, but even with this relatively short follow-up time, we noticed that there was approximately 6,000 individuals with post-COVID syndrome, and 1/3 of them had not received any contact with the healthcare system. So, okay, so perhaps for this 1/3, the initial COVID infection wasn't super severe because they had not contacted like a more granular treatment, or definitely were not hospitalized. But then the more severe disease and more contact with the healthcare system they had, the higher the risk or the association with long COVID also was. So that's the first point. The second point I want to make is that the symptoms and other diagnoses that associated with long COVID in the Swedish data were very similar that had been reported in questionnaire data. So we had diagnoses and reports for dyspnea and malaise and fatigue, which are currently considered some of the most frequent symptoms after long COVID. And if you're more interested in the findings from this study, we have put it available as a preprint. So now, luckily, so I work at the Finnish Institute for Molecular Medicine in University of Helsinki, and they have put together, I think there's a little bit of echo here. Okay, now I think it's good. So I work with Andrea Ganna and Mark Daly, who put together the host genetics initiative for COVID-19. And at the early times of the pandemic, many different research groups had the idea that we have to do something about the disease and we have to understand the biological mechanisms. And at first, everyone was collecting their own samples and really doing very local research. But what then the COVID-19 Host Genetics Initiative was able to do was to unite really the efforts across many different countries and many different research groups, so that they could analyze genetic risk factors for susceptibility and for severity and for hospitalization. And our work on long COVID was really possible because the infrastructure was built already in place. So ideally, you don't share, like it's easier to share, for example, summary statistics across countries than individual level genetic or epidemiological data. And the pipelines and the resources that were created by the COVID-19 Host Genetics Initiative then enabled us to do the same work that for long COVID phenotypes. So what we did, we contacted the same research groups and did essentially the same comparisons to understand the biological consequences and risk factors for long COVID. And we had 4 different analyses that we did. We compared those individuals that had test verified COVID-19 infection and long COVID, then to either COVID survivors or to general population controls. And the vast majority of our samples in the data freeze 4 that was from last fall comes from Europe, but then we also have a few cohorts from US and a couple of Asian cohorts as well. And I cannot stress this enough, so because the diagnosis criteria and the questionnaires were already also developing at this time when we built this study. It was extremely important to harmonize, first of all, the comparisons between which cases are compared to which controls, but also the phenotype definitions. So we use the WHO definition so that people need to have had symptoms also after 2-3 months after the initial COVID-19 disease. So that's one thing that, so a lot of effort also went into this data harmonization. And after this, I'm just going to show you the results. I'm going to walk you through this plot because I know that not necessarily everyone has been looking Manhattan plots before. So this is a genetic analysis that we did. So here on the x-axis, you have chromosomal position starting from chromosome 1 and ending with 23. And on the y-axis, you have the significance values, so that it's a negative log 10 p-value. So the higher the dot is, the more significant it is. And here each dot represents a genetic variant. So essentially we can identify these regions of the genome that stick up here like Manhattan skyscrapers. And then those are then going to be our hits for long COVID in this case. And we had with this data phase 4, we have about 3,000 long COVID patients and about 1 million population controls. And our genetic hit comes in FOXP4, which is a transcription factor that modulates immune responses and participates in lung function. And FOXP4 is actually quite an interesting gene because it has come up earlier in COVID severity GWAS. And this was very interesting for us because we had seen a very similar result from the Swedish COVID-19 data, where severity was one contributing factor. And we were thinking like, are we just like picking up severity, or is there like a specific FOXP4 association with long COVID? So I'm going to talk about that in a couple of slides, but let's look at the actual locus a little bit more, because I want to share a couple of other resources that we use in genetic data. And first of all, this type of analysis that I'm showing here is a meta-analysis. So we combine summary level data across a bunch of different cohorts, and in this case, across 24 cohorts. And what you can see is that here we have the effect estimate plotted, and then we have the standard errors around the effect estimate. And then this makes harmonization of the effects and combining the effects way easier than exactly like sharing the individual level data. And then we have a little bit narrower confidence intervals here in these three cohorts here, because the allele frequency and power is actually bigger in the Finnish and the non-European cohorts. So it's more frequent, the variant right there. And then a really interesting thing about this variant specifically is that the genotype is associated with higher FOXP4 expression, and especially in lung and somewhat also in hypothalamus. And here you can see the values plotted nicely by the risk alleles. And then if we do formal evaluation, if it's a shared effect between long COVID, so we plot the p-values for gene expression by gene p-values by the long COVID, we can see that there's this correlation where the lead variant for both the expression and for long COVID is shared at the top right corner, and the posterior probability for this being a same signal and a shared signal is extremely high. So then going into the other available data sets is that sometimes it's useful when we have, for example, here with this particular finding, we have a bunch of correlated variants. So they actually form a haplotype here, so the genotypes are correlated, but we can use data from the ENCODE and the Roadmap project, which have collected tissue samples and assessed active transcription and promoter sites for those specific tissues. And then we can start understanding that if we have a genetic variant here, does it align, for example, in this enhancer element right there? And that will give us biological clues what kind of mechanisms might be driving the really at biological level and at clinical level, then the association with long COVID and this variant. And we can make a nice figure also showing like how those effects are distributed across different tissues. And this is then data from the Regulon project. We're going to see that active enhancer signal is here located in the lung, but it also is relatively pleiotropic, so that it's also expressed or has enhancer signals elsewhere in the genome. So then let's go back to the question about if severity is a risk factor for long COVID. So we utilized a method called Mendelian randomization, where that utilizes really the Mendelian laws of alleles in a way that you randomly inherit either risk allele or alternative alleles from your parents, and then this randomizes the genetic makeup of offspring, and it's a little bit similar setup as a randomized controlled trial might be. So if we plot then in the MR setting, we can plot the effect sizes for COVID-19 hospitalization, for COVID or long COVID, and then compute what is the slope here between the two. And then we can see that when hospitalization risk increases, so there's risk for long COVID. And this is evidence towards that COVID hospitalization would be actually a risk factor for long COVID. And if we want to examine this at variant level, we can then assess how likely it is that the variants are specific for COVID-19 hospitalization, or that they would have a joint effect for both hospitalization and long COVID. And for this FOXP4 gene that we found, it was actually even higher a probability for being a joint effect between both COVID-19 hospitalization and for long COVID, whereas majority of these variants that have associated with COVID-19 hospitalization before were specific for COVID-19 hospitalization and did not show any strong evidence for having an effect on long COVID. So FOXP4 seems to be kind of like an interesting outlier in a biological sense for contributing to the risk for long COVID. So this leads me to my final point that next, I think we need to use similar data sets to really understand the heterogeneity of symptoms in long COVID, ME/CFS, and dysautonomia that are frequent conditions after these viral or bacterial infections. And one of the most interesting phenotypes that we've been interested in is, of course, Raynaud's disease, which is also relatively frequent in long COVID patients. But I want to summarize, and just like for the data structure and collaboration side, say that really the Nordic and global collaboration have enabled us to detect genetic and biologically meaningful signals for COVID-19 and now also for long COVID and for these post-viral diseases. And then just summarize that for long COVID specifically, we've shown that it associates with, along with a lot of other research groups, it associates with fatigue, dyspnea, and the variants at FOXP4. And just want to acknowledge the team and the resources that have been provided to make this study possible. Thank you.
Thank you very much. Excellent example showing how the data infrastructure can support the research. Our next speaker is Dr. Tony Thaweethai from Massachusetts General Hospital. So Dr. Thaweethai completed his PhD in biostatistics at Harvard before joining the faculty of the biostatistics group at the Massachusetts General Hospital. And now he's the Associate Director of the Biostatistics Research and Engagement. He's also the lead statistician in the data resource core at the MGH for the NIH recovery initiative. The goal of which is to seek to understand, prevent, and treat post-COVID infection, including long COVID. And his talk also going to focus on the studying of long COVID in larger observational cohort, the recovery initiative. Tony,
Thank you. Thank you. Okay, so great. Thank you so much for the.
Just 1 second. Let me see. Okay, go ahead.
Thanks. Thank you very much for the introduction, for the invitation. I'm really excited to talk about long COVID. I think it's a really nice follow-up to the previous presentation and talking about the Recover Initiative. So I'm going to be talking about the Recover Initiative, which is an NIH-funded, very large study to look at long COVID in a variety of different ways. The component that I'm the most involved with is in the observational cohort that has been enrolling since towards the end of 2021. But I'm going to kind of walk through how Recover came to be, what the objectives are, some of the challenges in studying long COVID in an observational cohort, and kind of its place in terms of pandemic preparedness and pandemic response. So just a disclaimer that this, what I'm going to be talking about today is more in my capacity as a researcher at Mass General and not necessarily as a representative of NIH or of the Recover Initiative as a whole. So I'm going to talk a little bit about what long COVID is. We've already heard a lot, which is fantastic. I'm going to talk about Recover as pandemic response, some of the organizational structure of Recover, and then also the observational study itself, and then finally some of the challenges and opportunities that we have with Recover. So I'm going to refer to long COVID kind of interchangeably with PASC as PASC, which is the post-acute sequelae of SARS-CoV-2 infection, or PASC. And so, most people get better within weeks, but that's not always the case. And some people do experience long-term conditions, and it includes a wide range of new, returning, or ongoing health problems. It's associated with all ages and acute phase disease severities, where we're seeing that often individuals who are sicker earlier on are the ones who tend to develop long COVID, but there's still a lot to explore within that. This was a really fantastic review that was published at the beginning of this year by Hanna Davis et al. In Nature Reviews Microbiology, looking at more than 200 symptoms that have been identified with their impacts on multiple organ systems. It can affect many different organ systems and has many adverse outcomes. And in some cases, these symptoms can last for years, they can be lifelong, and many individuals with PASC are unable to return to work. There's a lot of different causes of PASC being investigated. Some people believe that there's persisting reservoirs of SARS-CoV-2 in people's tissues. Immune dysregulation impacts on microbiota, also of course genetic predispositions, as was just discussed, as well as mechanisms related to endothelial dysfunction. There's a lot of suspected risk factors that people are interested in understanding, such as sex, comorbidities such as type 2 diabetes, connective tissue disorders, and specific autoantibodies. And currently, there's no validated effective treatments for people who have long COVID or PASC. So in February 2021, the NIH put out an AROA for at the time, it was not called Recover. It was an initiative to study post-acute sequelae of SARS-CoV-2 infection. They were looking to both recruit, identify institutions that were interested in recruiting patients into the study, as well as establishing a clinical science core, data resource core, and a biorepository core. And so my role is as the lead biostatistician within the data resource core, which is housed at Mass General in Boston. And so anyone can go onto now recovercovid.org, which provides a summary of what Recover is and what it's trying to do. So Recover stands for Researching COVID to Enhance Recovery. And it includes, many different aims, which I'll describe. So the goal is to rapidly improve our understanding of an ability to predict, treat, and prevent PASC, including long COVID. And importantly, this study includes not just adults who have and do not have a history of COVID infection, but also children, which make up a large component of our study. There's a particular manifestation of COVID amongst children called MIS-C, or multi-inflammatory system disorder and syndrome in children. And this is a condition that can be really debilitating for children. There's also a lot of interest and emphasis on people who are pregnant and understanding whether having COVID either before or during pregnancy will impact both the person who is pregnant as well as the child. And so we have this kind of linkage, which I'll talk about shortly, between the adult and the pregnant adult and the child or the infant, to understand whether there's a relationship or link between illness during or before pregnancy. So the principal goals of Recover include characterizing the incidence and prevalence of PASC, understanding the spectrum of clinical symptoms, subclinical organ dysfunction, natural history, and distinct phenotypes identified as PASC, as well as identifying these various risk factors that affect both someone's propensity for developing PASC, but also their ability to recover from PASC, which is what we're really interested in as well. Are there reasons why some people develop symptoms that last a really long time versus not. And then finally, to define the biological mechanisms underlying the pathogenesis of PASC. So RECOVER, as I mentioned, includes a large observational study, which is a cohort of cohorts. This is the part that I'm the most involved with, which involves adults and children, studying people who both have and do not have a history of infection. But RECOVER also funds a large number of electronic health records-based research studies, many of which are linked on the website that I provided earlier, where we're trying to kind of rapidly understand the distribution and the determinants of developing long COVID. There's also a large element of the study that involves pathobiology studies. And so these are studies where people are trying to look at biospecimens and other samples that are collected often during the acute phase of infection, seeing if there's any sort of immune response or some other response that's happening in the acute phase that may predict what's happening to people later on and may differentiate people who do and don't develop long COVID. So that's a very large part of this study where we're trying to understand the mechanisms of PASC and understand how we can understand why it is that some people get sick and some people don't. And finally, there's a large component of RECOVER that's also part that's related to clinical trials, which is trying to identify new treatments to help people who have PASC or long COVID. And many of these participants in these clinical trials are coming from the observational studies. So RECOVER as a whole is not an interventional study, but there are individuals in it who may enroll further into clinical trials to, which is one of the main reasons or one of the many reasons why people are interested in participating in RECOVER. So a little bit about the leadership structure of RECOVER. The clinical sciences core is housed at the NYU Grossman School of Medicine. I'm part of the data resource core, which is at Mass General and Mass General Brigham, where we're involved in developing the electronic data capture systems, study design, statistical analysis, analyzing the data, and so on. The biorepository core is at the Mayo Clinic, and the Administrative and Coordinating Center is at RTI International. Within RECOVER, there's also many principal investigators as we're recruiting participants from over 100 sites. And so there's a lot of committees involving principal investigators, and very importantly, patient representatives and patient advocates who contribute to study design, to contribute to monitoring, quality assurance, quality control, to ensure that the initiative is achieving its aims and is, truly generating a cohort and answering the key questions that people need answers to. So just very briefly, there's 3 observational cohorts. There's an adult pediatric as well as an autopsy cohort. The adult cohort and the pediatric cohort are linked in part by virtue of some adults being pregnant who then give birth to infants who are part of the pediatric cohort. There's also children who are enrolled into the pediatric cohort who come from the ABCD study or the Adolescent Brain Cognitive Development Study out of UC San Diego, as well as individuals with a history of MIS-C who are from the music study, which is another NIH-funded study that looks at a specific type of PASC. There's also a large autopsy cohort that recruits individuals who have passed, who had a history of infection, where we're doing autopsy studies to understand, again, the mechanisms of why people develop PASC. And as I mentioned, there's also large EHR studies. If this was all relative to, this is actually to scale, the EHR studies would of course be a much larger bubble given the scale of data that that individuals have access to as part of EHR studies. Just very briefly, I kind of talked already about the different cohorts. So you can log on to recovercovid.org and see where enrollment is now. Enrollment began in October of 2021 for the adult study. It began around 5 months later for the pediatric study, and the autopsy cohort began enrolling dissidents just shortly after that. We involve individuals who are and do not have history of infection. to understand, to have a reasonable comparator group, which presents many challenges, as there are individuals who believe they have no history of infection and may or may not have antibody results confirming that, but we also know that antibody results wane. So there's a lot of statistical and epidemiological challenges that come up when trying to develop a reasonable comparator group when you're trying to study the incidence of long COVID or PASC. So individuals enroll into the study. They're followed for up to 4 years after their index date, which is infection for infected participants, and a time of a negative test date for uninfected individuals. They're followed every 3 months with variable frequency for in-person visits and biospecimens, but we're asking them about symptoms that they're developing every 3 months over the course of the study. The study has had many challenges over the last couple of years. Initially, back when we think to, even 2 years ago when this was also, when just before Recover started, we didn't anticipate that the positivity rate for people to ever get infected would be so high. That there are a lot of uninfected people who became infected on study. Many people became reinfected, which we never anticipated at this point 2 years ago, or we thought the rate would be much lower than it currently is. And this has all led to, requiring a really flexible design. We've had to rapidly make changes to the study design over time. So I know that was a very fast overview, but I just wanted to, keep mindful of time. And so just wanted to reiterate to say that, PASC is a really complex disease with elements that we recognize in chronic illness, but there's still many unknown dimensions that remain to be explored. And when I think about Recover and our role in responding to the pandemic, it's very difficult when we have to define a new condition and a new disease that doesn't necessarily fit into the buckets of diseases that we have observed in the past. And our existing structures, research that just uses electronic health records, are limited in some sense by existing data elements. The long COVID ICD code wasn't introduced until October 2021. And there seem to be some specific manifestations of PASC, including post-exertional malaise, which doesn't have a specific ICD code, even though it's a very specific condition, feeling exhausted for a day or 2 days, or even longer than that, after exerting physical or mental effort. And so the data is only good as what our analyses are only as good as the data we collect. And so I think there's still this place for cohort studies where we can collect data in a structured and rigorous fashion, defining a new disease, talking to patients, figuring out what are the questions that we should be asking, rather than relying entirely on observational or rather on passively collected data using the structures that we already have in place. And so I think electronic health record studies and cohort studies can work well together to help us tackle the issue of long COVID and any other new diseases that arise in pandemics or other situations in the future. Okay, that's our presentation. Thanks everyone for listening, and thanks again for the invitation to present.
Thank you very much. Now we are going to have some questions from the audience and to any of the speakers. I think these are the three excellent examples and covering actually different aspects of the systems and data and their impact. Any questions? John?
Hi, I'm actually in the Recover study here at Cleveland University Hospitals. Is that looking also for genetic variations that might be associated with long COVID, or are you not doing that?
So there's less of an emphasis on genetic associations as it is on biospecimens that are being collected, but I can't speak to all of the pathobiology. I think that's in the realm of all the pathobiology studies that I believe some of them may be using genetic data, but I'm more involved in the symptom surveys and data collection and less so. So I can't, unfortunately, I can't comment on that.
Hey, thank you very much for those great talks. The last two speakers, I have a question. You know, obviously there's a lot that we still don't know about long COVID, and the disease is changing, just like the germ itself is changing. And an example of that to our last speaker is with the pediatric post-COVID syndrome of MIS-C has really dropped off a cliff with the introduction of the Omicron. And we don't see nearly as much of that as we did with Delta or with Alpha. And so I guess one question I would ask to you is whether or not you're seeing a difference in the symptoms or in the prevalence of long COVID with the different variants that we have seen since you started studying in 2021.
Yeah, that's a great question. Yeah, so it's definitely the case that the rates of MIS-C seem to be lower. I think with the pediatric participants that we've been recruiting into the study who have a history of MIS-C, often the scientific questions are not even anymore like what makes people more or less at risk of developing MIS-C, but rather, how can we better care for these individuals? Can we understand the mechanisms of their disease, like doing studies on them to understand like how we can better treat them. I think in general, though, across all the cohorts, we're seeing some different manifestations of long COVID. I think, we're seeing one of the things that was like the hallmark of long COVID earlier on was people who had loss of smell or taste that persisted over a really long period of time. That seemed to be more common amongst individuals who were whose initial infection was pre-Omicron, and we're seeing that to be less the case now. The jury's still out on the impact on children. We don't have enough data at this point yet to necessarily answer that and to do robust statistical analyses yet. But there just seem to be some trends analogous to what we're seeing in adults, but there's still a lot less that's known about what's happening in pediatric participants.
Hanna, I don't know whether Hanna, you want to have some comment on this too. You can just mute that.
Yeah, so I think one of the most interesting questions in the future might be the contribution from the different viral variants. And then, of course, the role of vaccinations. So we already, there is some relatively good evidence that vaccinations are gonna reduce the risk for long COVID. And some of that is presumably through reducing the risk for severe disease, and then just like reducing the amount of virus if you have like faster immune responses. So those are kind of like the interesting questions that I think we could tap into going forward. And I really enjoyed also very much both the first talk and the talk after me. So it's great. This is a great session because I get to connect with both of you too.
As I understand it, you were studying hospitalization and long COVID, with the assumption that hospitalization was a sort of a measure of severity of COVID. First of all, I'd like to confirm or deny that. As to my understanding of that is correct. If it is correct, I'm wondering if it could be that hospitalization also means that patients are under more observation for a longer period of time, and therefore it's more likely to be tenant on COVID.
I think it was for me, right? So I didn't catch the very last part of the question, but I think like the part about the genetic variants is that these are relatively common genetic variants in the population, and they increase the risk just a tiny bit. So they tell more about the biological mechanisms rather than are clinically predictive in a way. So that's currently how we're using these variants to understand the biological mechanisms. And of course, it's going into what you said about the hospitalization, that the fact that there is a lung phenotype together with FOXP4 and with the severity might be related also to lung pathophysiology in long COVID that could be shared with a bunch of other diseases as well. And I apologize if I didn't answer your question.
Oh, okay, thank you. Hi, fantastic panel. I have a crowdsourcing question for all of the panelists. Beth, you mentioned in your workup of the data sources for the Hopkins tool that the crowdsourced data was an input to something 3,000 public health departments. So I'd be interested to know what you consider to be viable crowdsourced data. And then for the cohort studies, I'm just curious how whether you were following up directly with symptom reporting and novel technologies for your long COVID cohorts, and that system applies across your different regions. In other words, whether you're going outside clinical mechanisms to gather data that's relevant to your work.
I'm having a little bit of trouble hearing, I think, with what's coming from the room, but I think that we're talking about like how we tolerated crowdsourced data and the collection, and then I think
change it a little bit. We're gonna ask the audience to come over here, and then we will see you on. And you can ask.
Yeah. The first question was, exactly, the novel crowdsourced data sources, and then the second was to the extent for the cohort studies, how are you gathering data from patients? Are you in direct mobile collection, or are you using a broader cohort or of symptom reporting in the way that we saw apps support through COVID?
Yeah, so I can start on the way that we kind of handled the crowdsourced data. So that, like I said, the very beginning of the data pool, it was all really manual, and also the local health infrastructure didn't have a platform for collecting some of the most basic data on cases, death, and testing. And so they were using and relying on a lot of crowdsourced data in order and different ways of kind of hacking data into their own platforms in order to get data that could get released on public data sites. We always would prefer to use a validated site, and our first sites were always those that were sponsored by the government. The government kind of was sanctioning, but we knew that when we lifted up the hood on those collections, that it was a mix of these kind of like literally driving around, taking hash marks on a piece of paper, moving that data into, manual databases and things like that, to more sophisticated abilities to use different platforms to pull the data. And so as we evolved in our own methods, we started to provide support to local health authorities, state health authorities, and even some instances the federal government on how the collection should be happening and ways that they can be systematized or standardized. And so the crowdsourced data was obviously, like I said, a function of the emergency. And then as we were able to get a little bit more infrastructure in place, that became less reliant. And it was more just feeding out of the sort of more concrete, well-worn paths that public health data was moving into places. The CDC also played a big role in the United States around this, because they, during emergency use, would allow essentially for state and local governments to release death data without certification being finalized, which allowed us to get data faster, which I think really did help in research and in some of the harder understanding of the disease behavior itself in the community. But ordinarily, that data would not be released until it would go through a long processing between the states and the CDC, in which case we're seeing like 6 to 8 month lags, which is why our data was often preemptive of what was in other resources.
Okay, thank you. And Tony and Hanna, anyone want to comment on second question?
Yes, So the question was about symptom data collection in the cohort studies in Recover, and so it's a mix. It depends on the cohort that we're looking at, but it is still so in the adult study. I didn't have time to talk in detail about the symptom questionnaire, but this was we worked for several months with principal investigators who were recruiting patients into the study, with patient reps, patient advocates, to develop a symptom questionnaire that includes more than 50 questions about different symptoms that people might have, including things like post-exertional malaise. And people have the ability to, report whether they had the symptom around the time of their infection, if it's something that arose like between infection and when they're filling out the survey now, and if it's something that they're still experiencing now. And so it's part of a very, we use REDCap, like it's a structured survey that gets sent out every 3 months from the time that people enroll into the study. The in-person visits there's interaction with patients every 3 months in the study, but there's not always in-person visits. And so there's always an electronic link that gets sent out for people to indicate which symptoms they're having. In the pediatric study, it's similar. There's more age-specific symptoms that are asked about. We're not asking about issues in school for children who aren't going to school yet. And we have different behavioral issues related questions that we're asking. And then in the autopsy studies, we're relying more on electronic health records to see whether people had these different symptoms, or we're looking at visits that these individuals have had prior to their death. And so there's it's out of the structured format, and it's helpful because we're able to quantify the amount of missing data that we have more easily compared to registry or EHR based studies, where we know that somebody has a symptom in the EHR, but we don't know if they don't have a symptom, right? They may have just not had an interaction with the healthcare system at that time, which Hanna talked about in her talk. So I think that there's an important opportunity there that we're able to be somewhat more, there's obviously all the challenges of getting people to respond to surveys and all that kind of stuff, but there's also an opportunity to have different types of data when we use symptom questionnaires for people who are in this longitudinal study. So I don't know if that really answers the question about crowdsourcing, but I think the answer is that Recover is primary in the observational cohorts. It's more like a traditional cohort study with regular follow-up and trying to get good data that way.
Hanna, you want to comment on the poster initiative? That's a different story.
Yeah, exactly. So I'll comment briefly about the harmonization of the data, because in the host genetics initiative, what has been kind of like the starting point is that different cohorts had a little bit different questionnaires that, for example, they had sent out. So that's why we needed to, for example, harmonize then the phenotypes. So when we knew like how long follow-up, or when they had received the diagnosis or had the original test for COVID-19 infection, that gave us then sufficient information to send individual cohorts the information. Okay, this is how we want you to build the phenotype, and analyze the data, and they would analyze it locally and then send the summary results to us, and we would do the kind of like the joint analysis based on those summary results. So we were not designing a questionnaire that everyone would jointly use, but we harmonized everything that people had already done in their own cohorts.
So I have a follow-up question on that analysis. Actually, do you actually consider different population structure from different studies? This may be coming from different groups, different countries, continents. How you handle those?
Yeah, exactly. So what we do is that we do fixed effects meta-analysis and random effects meta-analysis. And within each cohort, we analyze each ethnicity and each population separately, and then adjust for stratifying factors, usually computed from the genetic information that we have. So we can adjust for genetic principal components, essentially, or relatedness matrix. And after we've adjusted each individual cohort, then only do we do this meta-analysis. And in addition to just like running a meta-analysis, we also run additional meta-analysis where for each variant, we leave the most significant cohort out. So the cohort that is providing the most signal, we leave that out and see that, like, do we still see a signal even though our best cohort is left out? So we do that kind of like leave on as analysis. And it's a great point about the stratification.
Yes, thank you. Any more questions from our audience? I think it's better. It's still the same. I think the same.
As questions for Dr. Blauer. For future pandemics, to you, what would a proactive, sort of robust approach from CDC look like for really leading the data collection process with, through standardization and coordinating, aggregating data? Have you thought about what that might look like?
Yeah, I've been thinking a lot about what that would look like. I think one of the biggest impediments to the way that the structure of data reporting happens here in this country is the fact that each state independently negotiates the flow of data between their public health system and the CDC, instead of there being a uniform set of standards that each state would adopt. They have the ability to negotiate both the timing, definitions, metadata, everything is independently negotiated. And I think the very beginning of this isn't an expensive fix. It's just stop doing that. Stop letting there be so much variability across all 50 states in the way that they and the tempo in which they provide data. I think it's an easy fix, and it would allow us to have a much more robust understanding of a lot of different public health challenges that we experience. There's also baked in there, like death certification is in those agreements. Lots of the statistical infrastructure that we rely on very deeply in the field of public health is all variable because of these agreements that have been built up over time. So for one, that would be the first thing that I would shift. And then I would come back inward at the CDC and start investing in a new set of skills. We thought, we observed the CDC to be flat-footed when it came to being able to kind of very agilely stand up data capacity, move data, analyze data, and start putting out analysis in a much more timely way. They are not used to turning data around daily. They're only used to these long processes that require a lot of bureaucratic overhead. And I think that there is a time and a place for making sure that we get clean, quality data that's very useful for long-term research and can power but there's also an agility that we need as public health leaders to be able to inform decisions day to day, whether that's where do I have toxic drugs in the community where people are overdosing, whether that's disease that's spreading very quickly, whether that's some of the big challenges that local leaders need much more real-time information about, can't get stuck in these churns that have these 6-month to 2-year lags.
Okay, thank you very much. Any more questions in the audience? Actually, Beth, I have a question regarding the system. Your system you just mentioned received so many requests in a very short period of time. How actually you handle this scale of the system? Do you guys use the commercial web hosting, or how actually you handle those parts?
Well, thankfully, we have APL as a partner, and they have a lot of computing power. So they actually hosted the data. And we did it all here in-house at Hopkins, where we were able to kind of babysit the system. It was immense. We had lots of people who wanted to build applications on top of the data that would sit within the dashboarding, but the reality is very few were elastic enough to be able to absorb the daily burden of just who's visiting and how much activity the data was producing from a rendering perspective. And so very thankful for our partners at APL that we have that capacity here internally at JHU. But again, it begs a bigger question, is that should that only live in places like JHU or in big cloud-based infrastructure, or should we start building some of this capacity internally in our public health organizations and government?
Yeah, that's exactly the point I want to hand it to, because from these three projects, we can see one of the projects is starting from research in the university. Another one is actually a group of researchers and then collaborated with each other and then have this initiative. The third one is supported from NIH, and it's a more traditional way of supporting such a project. I want to get some thought from all three of you. Moving forward, what do you see, like how everybody can work together and then make the data available and create a data source that people can use, not only research but also as a platform to inform public audience?
Yeah, I'd love to explore that further. I think that we, are thinking also about kind of like, we assembled this team that's been working on this for the last 3 years. We're now decommissioning our regular collection of COVID data, but that team continues to also support data collections across a lot of different outcome areas. And so I'd be happy to, in another conversation, talk a little bit about that work and see if there's an opportunity to collaborate.
Okay, thank you. Hanna and Tony, you guys want to comment on those, based on your experience?
Overall, for policy work and informing the public, oftentimes I feel like researchers only talk to researchers. And so that is the first thing, to have the conversation also with other people. And it has been wonderful here today to hear about everyone's work, but that's like at least one of my thoughts, that like communication in a way, it's key if we want to inform also the public or the policymakers.
Thank you.
Yeah, I want to echo that. This has been so great to hear everybody's perspectives on these topics. I think kind of in building this, my thoughts on this are kind of like, I'm working within this structure of like an old traditional cohort study. Like that's there can be a really high barrier to entry, right? It's like people who are interested and have the time to engage in research. People who not everyone even knows really, like, they know somebody has in their family or someone they know like has COVID and never really got better, but it's often people who have different like socioeconomic backgrounds who are able to articulate exactly like how they are feeling, who have the language for things like post-exertional malaise, exercise intolerance. And so I think that when we're trying to study something like a chronic disease like this that can be really debilitating, that there's so many people who are suffering kind of silently from it, and that we need to, like when we're doing these like cohort studies and we're trying to understand a disease that forces people to stay in their homes, like not because of the pandemic, but because they're not well enough to go outside, that we don't that we ensure that like when we build a cohort that it is accessible for people to join from who are not necessary, like that we can build a diverse cohort. And so I think in terms of, I don't know if I'm maybe going off on too much of a tangent here, but I think that there's an important messaging when we're trying to understand a disease that's impacting so many people, that that everybody has the opportunity to participate and contribute, so that we aren't just collecting really good data on a very small subset of people who are privileged enough to be able to participate in research. So I think to me, that's like an important part of understanding a new disease, is that that we're trying to be representative of all people who might develop it.
Okay, thank you so much. I think our time is run out, and